Okay, reassessment. If you look on your assessment sheet, your medical and trauma assessment, as you go down everything, there's a little entry that says reassessment, and it's close to the end. And reassessment is a continuous thing that we will do. In this chapter, we're going to look at how to do a reassessment, and we've already talked basically about the importance of getting repeat vital signs. Why is it important that we get repeat vital signs? We're looking for trends, exactly right. So we won't have to spend a lot of time on that one because I think you've got it. And we're going to look at the difference in reassessments for a stable patient versus an unstable patient. If they're unstable, how long must you recheck their vital signs and reassess them? Every 5 minutes. If they're stable, how often? Every 15 minutes. What makes them stable or unstable? How can you recognize a stable patient? Their what?
Their mental status.
All right, their mental status is good? Yes, what else?
Breathing.
They're still breathing, that's always good. Yeah, they're breathing, their vital signs basically are within normal limits. So they're alert and oriented, they know what's going on, and their vital signs are within normal limits. And they don't have like great severe pain. Somebody with a very severe pain, we might put them in the critical category too. So we'll be looking at the difference in those two assessments. All right, you got your trauma sheets? You got that out? You pull that out. Did anybody not? What are we going to do with you? Why don't you bring yours and just leave it in the classroom? You can have your classroom one and your lab one. How's that? All right, so much for that. All right, look on there. Find the reassessment on your medical sheet. Yeah. Where's your reassessment on your medical sheet? Yeah, it's like next to last. So yeah, this is what we're going to do at the end. So with our reassessment, we always go back and do our initial assessment. If it's every 5 minutes or every 15 minutes, it doesn't matter. But what's contained in our initial assessment? You should have memorized this by now. The initial assessment of the primary assessment, number 1 is, who said it? General impression. What's 2?
Chief complaints.
Do what? All right, your LOC, level of consciousness, and then chief complaint. Remember, we do all those without touching the patient. All right, now we move into what?
ABC.
ABC, and A is?
Airway.
Airway. Is the airway patent, and is it maintainable? All right. B?
Breathing.
Are they breathing? What are we looking for? Adequate or inadequate, right? If there's anything wrong with them, we want to fix it. What else? Yeah, we're looking for rate and volume. That's going to be, is it adequate or inadequate? What else are we looking for? What else are we going to do there? If you look over here, there's still spaces that these people still need to sign. So yeah, what's the quality of their breathing? Sure. How are we going to manage them? Under B, think of what the little, you can look on there. Under breathing, we've assessed them.
Therapy.
We may have to, oxygen therapy. So we're going to decide what type of oxygen therapy to use. Now, in reality, there'll be times when we won't use any oxygen therapy. However, these registry sheets say, apply appropriate oxygen therapy. So you just decide, is this a nasal cannula, is this a non-rebreather, or is this bag valve mask? Basically what we're looking for. And so that's A, B, what's C? Circulation. What's covered in circulation?
Bleeding.
Pulse rate. And what are we looking for on the pulse? Yeah, so it's regular, irregular.
Steady.
Quality, basically, is it strong, is it weak? Right? What do we want to know about rate?
Is it fast or slow?
Fast, slow, or absent? And then what's the last part of that? The what? I thought you were going to cover the last part of that. C. Circulation. You got to check skin signs. Manny, what are the parts of skin signs? What? Color of skin. Temperature of the skin. Condition of the skin. Condition is what?
Wet or dry.
Basically wet or dry. Okay, so we've done skin signs. after that? You said a minute ago. Under circulation? Yeah, bleeding. Is there any bleeding or any bleeding control that you need to do? And remember, under ABC, if there's anything that's emergent, anything that's critical, or anything that you find that could kill your patient, you got to take care of it right then. And we haven't talked about a open pneumothorax yet, but say you had a patient who had a gunshot wound to the chest, and they had a big hole in here. Remember we talked about this? They're trying to breathe through the hole. Well, that's a real problem for A and B, right? So you will manage that right there. You'll put your hand over it until you can do something more definitive. So with ABC, you've got to assess and correct and treat. So you'll do that in ABC. So what's the next thing you do after ABC? Transport decision. Yeah. So here when it says continues on initial steps of assessment, we go back and we do our primary assessment. We recheck our primary assessment to make sure their ABC is still good. Make sure their level of consciousness is still good. See if they've changed as far as their chief complaint. Now they have something else going on that's bothersome for them. And then we may reevaluate our transport decision. It could be we decided, you know, they're stable, we don't need to rush. But now when you recheck ABC, you know, they're not breathing well, their O2 saturation has dropped or something. So we may decide, oh, we're going to go lights and sirens because it's more serious. So that's going to be our reassessment of the initial or our primary assessment. So we'll always do that. We're looking for changes in trends. Can you think of another change you may be looking specifically for? Say you had a patient with chest pain, and he told you it's substernal right here, feels like an elephant sitting on my chest. Pain radiates to my left shoulder. He says his pain is 6 out of 10. You've helped him with his nitroglycerin. You've given him an aspirin. You've given him some oxygen. So what would you want to do in your reassessment of him? Has the pain changed? A minute ago you said it was 6 out of 10. How would you rate it now? 8 or 4. Is the specific number really important? What are we looking for?
The change.
Yeah. His assessment of it, has it gotten better or worse? It's not the specific number. Yes. What reassessment identifies? Any changes? Any trends? If the patient's deteriorating? If they're getting better? Remember, patients are dynamic. They change. Just as we say your scene is dynamic, your patients are dynamic. They rarely stay exactly the same. We want them to get better, but we certainly want to recognize if they're getting worse. It's important that you communicate with your patient all the time. Talk to them. Let them know what's going on. If they're anxious and they're worried, which who wouldn't be, how's that affecting their vital signs? How's that affecting their health, you think? Their what? Yeah, if they're scared, their heart rate's going to be up. If their heart rate's up, what else is happening then? Their what? Yeah, the blood's trying to get around more, but if it's going really fast, the heart's not refilling. So we have a drop in cardiac output. So if that happens, what's the effect on perfusion?
It decreases.
Yeah, it may decrease perfusion. Plus, when the heart's working harder, it demands more oxygen. And as that happens, then if you can't get enough oxygen around, the patient may deteriorate. So talk with your patient. Keep them calm as the best you can. Don't let them worry about it. I know for me personally, I'd be really worried about having to tell all you guys I went to the hospital in an ambulance. I'd be so embarrassed. So that would be very embarrassing for me. You guys probably might thrive on that. Oh, I got to go in an ambulance this weekend. But not so good for me. Now, when you're repeating your primary assessment, and you may do that several times throughout your transport, but you're looking for changes that might be life-threatening. If your patient was breathing 16 times a minute, now they're breathing 10 times a minute, is that a positive change or a negative change? That would definitely be bad. So that's something you want to make sure you catch. You want to reassess their mental status. You know, if they've got a blood sugar problem, they may be having a deteriorating mental status. If they're hypoxic, they're not perfusing, the mental status may go down. They may have ingested, an overdose of medication or pills, and when you got there, their mental status was good. But 15 minutes later, they're going downhill. So you have to constantly reassess their mental status. One way you can do that is just by having conversation with your patient. Talking to them about what's going on in their lives, what they're up to, or how they're feeling, and you'll notice a decline in their mental status without having to say, can you say your ABCs backwards or some nonsense like that? I couldn't do that. Checking the airway, monitoring breathing, still doing your ABCs, just as we said. And we look at your patient priorities. You're going to reassess your vital signs because we're looking for trends, right? Compare them to the baseline. If you just look at the one before, it may not be much change. But say it's your fourth one, you go back and look at your first one, you're going, ooh, not so good. Check their pulse oximetry again. Make sure that that is above 95%. Make sure they're still breathing well. Make sure you document everything as it's happening. If you have a 45-minute transport or you're with a patient for 45 minutes total, say 20 minutes on scene and then 20 minutes en route, drop your patient off, turn over patient care, get back to write your patient report, and you've got all those numbers in your brain, not good. Because what's going to happen is just before you write down that report, before you start writing all that stuff down, you're going to get another call. And that call's going to look just like the last one. And you're going, was that blood pressure 160 over 80, or was that the second patient or the third patient? So you need a little book. I carry a little notebook with a little spiral on the top. And every day I start with a new sheet, and I'll put 1. And then I'll write all the information about that patient. I may put their name, I usually put their name, any identifying information. I'll put their vital signs, I'll put their chief complaint, I'll put the medications they're on, any allergies, and then when I go to patient number 2, I put a little 2 up there. And then I document all that as I go. Because there will be times where you may run back to back to back to back call, and then now you've got to go back and recreate all that information for your documentation. And they all run together. You will not remember that. But if you keep that, you can just flip through it. And I usually start number 1 out with the date. I've had times where I could flip back weeks and weeks on one of those. And I can say, I had this patient 3 weeks ago. I can flip back and see what was going on there. Have a lot of information about them. And then I always kept those. They tell you shouldn't keep that stuff, but I always kept mine. But if you ever have to go to court later on, you've got that stuff, it's just nice to have for your own records. But you do get in the habit of taking something and writing that stuff down as you do it. If you take 5 sets of vital signs, then you go there to recreate that after the call, you're never going to remember those. If you're trying to watch a trend and you haven't written those down, you won't remember them. I know y'all are all really smart, your brains work really good, but all it's going to take is something distracting. You have an ambulance wreck. All that information before that is gone from your brain. So, write it down. Think of an example of a problem that might develop into a life threat to a patient on the way to the hospital. What bad could happen? Their heart could stop. That's never good. You could what? We could have an accident? Yeah, that's never good. Your patient could have an aneurysm. They could have all kinds of stuff. So, you've got to constantly reevaluate them. Mental status in particular is something you're always going to recheck because that's an early sign of hypoxia. It's an early sign of blood loss. It's an early sign of a lot of things going on. So always check for mental status. Okay, you're going to repeat your focus assessment. Who gets a focused assessment? Somebody with one complaint. That you can zero in on just that one thing. If they've, had a wreck, been ejected, are you going to be doing a focus assessment on them? No. So focus assessment is on a patient that just had one isolated issue. Always ask your patient, how are they feeling? Has anything changed? Are you better or are you worse? What's your pain level? If you've given them any medications, make sure all that stuff's still working. You probably should repeat your physical exam of that focused area. If they had some breathing, some respiratory issues, you auscultated the lungs, listened for breath sounds during your initial assessment, but you also want to continuously reassess those as part of your reassessment. So hopefully their lungs clear up, but they might not. Recheck any interventions. Now, at the EMT level, intervention might be what? Intervention is anything that you do for your patient besides, not an
Innovation.
assessment, but like oxygen would be an intervention.
Innovation. Intubation.
I hope you're not intubating, are you?
Oh.
Yeah, anything you've done, if you've given them some medication, say you gave them an aspirin, or you assisted them with their nitroglycerin. One thing about nitroglycerin, if your patient's not used to taking it, it has one pretty significant impact. Can you think of it? It often gives you a headache. It can also drop your blood pressure. So if you have a patient that you give a nitro to, and initially they had a blood pressure of 110, they could have a blood pressure of 90 now. So you want to constantly reassess them and recheck any interventions. If you put them on oxygen, if you've got a non-rebreather, make sure you look and see that that bag is still inflated. Make sure you've got enough oxygen in your tank to continue that. We mentioned repeat your focused exam and your physical exam. So the focused exam is going to be on a patient that just has an isolated problem. Repeat physical exam is going to be the patient that you're doing a full body assessment on, right? Okay. Mention interventions, oxygen, check for bleeding. If you put a splint on a patient, you want to make sure you haven't cut off the blood flow there. Like if it's swollen, you want to make sure you can loosen that. And then anything else that you're doing. All right. Observing trends. As I said, you're going to do your reassessment very frequently, depending on if they're stable or unstable. Watching for vital signs. And you may adjust your treatment based on how they're doing. Say you put them on a nasal cannula and initially their pulse oximetry was 96%. And then 10 minutes into it, you're doing your reassessment and you look and you see their pulse oximeter is now 91%. What might you do?
Just put a non-breather.
Yeah, say you had them on 2 liters, you might bring it up to 4 liters. If you had them on 5 liters, say, and their pulse ox is 91%, then you want to switch them to a non-rebreather. If you look up at them and you see they're breathing 6 times a minute, now what are we going to do?
BVM.
Yeah, we're going to use a BVM. So, the more serious they are, the more frequently you're going to reassess them. So that. If you believe there's been any change in your patient, if you see a change in the mental status, then you're going to repeat your primary assessment right then. Stable patient, you'll still repeat, but you do it less frequently. Every 15 minutes. If they're unstable, you may even, if it's an unstable patient, say they're having a respiratory problem, you may constantly reevaluate them. You may not wait 5 minutes. If they're bleeding, you may not wait 5 minutes. So you do it as frequently as you need to, but a minimum of 5 minutes. So everything pretty much is the same. It's just the frequency of which you'll perform your reassessment. So your reassessment is the last step in your assessment of your patient, but it's an ongoing process. If anything changes, you need to make sure you reassess them and then manage whatever the change is. What must you do if your reassessment turns up one of these findings? Gurgling respirations.
Suction.
Good. Bag on the non-rebreather collapses. Increase the oxygen flow. If they have snoring respirations,
Check it.
check the airway. Reposition. Make sure the airway's open. See, that's a little chameleon, isn't it? That was pretty quick, wasn't it?